on to this joint meeting of Westminster and Kensington Chelsea Health and Wellbeing boards. I just want to point out that as the last meeting was held by Westminster, I propose that I lead the discussion for this joint meeting of Kensington and Chelsea and Westminster Health and Wellbeing Board. And I ask the RBKC board if they approve of this proposal, although I'm not sure we have many members. But let's see, I put it out there. I'll take silence as golden. Sounds good. And then Tim, would you like to ask the same?
And I put the same question to the Westminster members, please. And again, dissent rather than assent.
Okay, silence being golden, we can move on. So as you'll all be aware that the High Court has ruled that formal council meetings, including the Health and Wellbeing Board, must take place in a single specified geographical location, and that all participants must be present in the designated meeting place, with the meeting open to members of the public. However, if no formal decisions are being made, the meeting can be virtual, as COVID restrictions remaining. Oh no, okay. As there are no formal decisions being made at this meeting, it's being held via Microsoft Teams with participants joining remotely. The event is also being streamed live on YouTube for those of you unable to make the Teams link, and members of the public and media are welcome to remotely follow the meeting and listen to the discussions. Committee papers for this meeting are available on our websites and via the calendar invite. And due to the size of the board and to ensure the virtual meeting can run as smoothly as possible, only official board members presenting papers and everyone who has requested a speaking slot can participate in this meeting. Everyone else should be able to view the meeting via the public live streaming. Any questions from the public are submitted in advance to ensure public accountability. So just a few house rules, as we're all used to now, just to make sure that your microphones are muted unless you've been invited to speak. Videos should be off as much as I'd like to see your faces to conserve bandwidth. And if I lose internet connection, Councillor Mitchell will step in as a substitute chair, but hopefully the town hall internet will keep us going. If any participants wish to speak during the meeting, they should use a chat function in the top right corner of their screen to ask to speak or to submit a question. So if we go on to item 2, which is membership, the only information to note there is that we've received apologies for absence from Councillors Rendell, Barnes and Bernie Flaherty. Darren Tully is now retired from the London Fire Brigade as well. And moving on to item 3, we have declarations of interest. And so I ask if either board's members or officers have any interest to declare in respect of items to be discussed. Again, silence is golden. And then I to ask whether there's any other matters arising at all. Which again, I take nothing gold. So on to item 4, which is minutes of the last meeting. So I ask both boards for their confirmation that the draft minutes of the concurrent board meetings on the 15th of July are an accurate reflection of the meetings. Thank you, Nasika. I'll mute people as we go. And then we're now moving on to item 5, which is a homelessness verbal update from Sarah Crouch, who's the Borough Director of Public Health, to present a verbal update on partners' work to support homeless people and rough sleepers during the winter period. So over to you, Sarah, if you're here.
Thank you, Councillor Kamali. Yeah, and I'm actually going to do a bit of a double act with Joe from Borough Director of Central London. And what we're really going to talk about is very briefly just the significance of homelessness in both boroughs and what we've done so far to protect homeless people from COVID, particularly people sleeping rough and in our supported accommodation. But really use this as an opportunity to set out our stall in terms of what we want to do in the future. And we propose to bring a written paper to the next board. So really just wanting to use this as an opportunity to engage board members in what you would like covered and discussed in that paper. So really it's just a starter for 10 today. Okay, so as a brief introduction, I guess we wanted to just flag the significant work that's underway in both boroughs to reduce the risk of COVID. We see still a significant number of people sleeping rough, particularly in more of an issue in Westminster, but we have a large number of people in supported accommodation in both boroughs, where COVID transmission is the risk of it is much greater due to sharing of bathrooms and kitchens. And although kind of broadly speaking, COVID sort of measures and masks and social distancing and so on are in line with step 4 of the roadmap, are of a less high profile at present, there's still a significant risk for those people in those sorts of settings. Those that are experiencing homelessness are more likely to experience physical and mental health problems. We know the average age of death is 45 for men and 43 for women. And those individuals, therefore, are much more vulnerable to serious illness and death from COVID. And we know, particularly with the impact of COVID and the lockdowns, we know that sort of homelessness may be a consequence of health problems, and certainly it's a cause of homelessness is a cause of worsening health. So it's really important that we think not only about people that we need to protect, but also the on the horizon potential increase in homelessness as a whole, as the reduction in furlough and the concerns that we have about economic downturn. So I think really important to flag the work that we have been doing. So we have had a multi-agency outbreak control team running right the way through from the start of the pandemic. That team's really responsible for identifying and acting rapidly in response to any suspected or confirmed COVID case. We have commissioned a specialist homeless health outreach testing team called Find and Treat, who can go into settings and support people on the street if we're concerned about a risk of outbreak. And we have provided on-site testing in settings where we think outbreak risk is greatest. So that's still something that we very much support. And we do lots of sessions and webinars with providers to ensure that they're up to speed with the latest guidance, and we're giving them adequate support to ensure that they mitigate all risks. We've also utilised to good effect self-isolation facilities, so we move people quickly out of shared accommodation if it's necessary to reduce the risk of transmission in settings where lots of vulnerable people might live. So not only is it it's a wraparound support service to ensure that people's health is monitored and they're staying in a safe environment, as well as protecting those who are vulnerable within the setting which they've left. So at this point, I'm just going to hand over to Joe, and I'm sure he'll want to talk about the approach that we've also done around vaccination and the multi-agency response. Joe, over to you.
Yeah, so just following up to what Sarah was saying, we've been, over the last 6 months, we've had a multi-agency approach in terms of vaccination led by our health colleagues, with input from local authority, from social care, from the third sector as well, which continues as well. Just want to give a quick update in terms of the last sort of, I suppose, the last 14 months of work that's happened around the homelessness agenda during COVID as well. We've had everyone in campaign, where Westminster, our multi-agency team of housing, social care, public health, our community nurses and the third sector have triaged, over 803 people across sort of 27 hotels across North West London. We've been leading on this across the 8 boroughs as well, and very much making a success of that, and continuing to house our homeless residents through that as well. Our RBKC housing colleagues is hosting our homeless health discharge work for the 8 boroughs as well, which is really good. We've received £1.2 million for this year in terms of developing hospital-based specialist homeless discharge teams, which really sounds like a mouthful, but really it's our first multi-agency, multidisciplinary team of both housing, third sector, acute, community and public health colleagues that are working to help really work with our residents who are staying in a hotel longer than they should be, and really working through a lot of the issues that they face that are quite complex. We're also, we've been now bringing together sort of our homeless team, and have appointed a new GP clinical lead as well across the borough, and also looking across the 8 boroughs as well. So there's definitely a lot of work in this area. And in terms of where we're trying to kind of go or head towards, we're going to be, Sarah, myself, and the rest of our team are going to be bringing back a proper update paper next week. Not next week, for the November Health and Wellbeing Board, which is going to look at sort of how do we make this business as usual, and how do we continue with the strong multi-agency approach that we are very much championing in Westminster and RBKC, but indeed across North West London as well. And we'll be also looking at other recommendations as well in terms of work that we need to do. And, you know, recently we've been linking in with Camden as well, just to share good practice and sort of looking at sort of not just homeless residents, but looking at refugees and other sort of other residents who are showing up as well. So anyways, it's just a brief update, giving us a bit of a flavour on the homelessness update. And yeah.
Great. Do we have any questions from anybody in the room at all? James, your hand went up.
Thanks, Councillor. So I, as the ICP Director and Discharge SRO for North West London, I absolutely endorse this work, and I've met with the team only yesterday just to get an update. I think it's a really exciting piece of work that brings together multiple agencies, and I do plan to discuss it specifically. We're having a joint workforce and task force group between North West London and North Central London, because we recognise that some of our residents who may be sleeping rough or are homeless may be without sector as well. So we're going to pick that piece of work up with our colleagues across the border.
Thank you. Thank you. Councillor Mitchell.
Thank you very much indeed, Chair. Just to follow up on James' point, borders are not recognised by most people, and I think it's really valuable that if we do some of this work in conjunction with Camden, because particularly in the eastern part of my ward, St James's, and the eastern part of our West End ward, immediately to the north of me, then quite a few of the services those people access will, including UCH, are out with our borders, and it's really important that we work together to serve this very vulnerable community.
Absolutely, and I share the sentiment there. Just one question, Sarah. You mentioned at the beginning you hired a consultant or something. That's news to me. Who exactly is that?
Was it Find and Treat? Is that what I mentioned?
Yes, exactly. It's the first I've heard their name.
So it's a Pan-London agreement. So every borough has contributed to their. They're a specialist inclusion health team that go out usually and do mobile TB screening, and they're based out of UCLH. And they've provided a great deal of support across Westminster and RBKC, going into settings, providing on the ground testing and assessing risk of outbreak. So it's a small amount that we've paid as a consortium in order to secure that service.
Great. Okay. Do we have any other questions from the room at all? I think that pretty much covered everything, really. It sounds really positive and a good way of working. Yasmin, you've got a question.
Just to let you know, Chair, that following this, we have a brief epidemiology update from Anna Raleigh.
Excellent. Okay, well, I suppose that's coming next then. Anna, if you're ready to go.
Yes, and Yasmin, thank you very much for sharing the slides. So the data in the slides, which will be in front of you, it's just come up now, is for the week ending the 29th of September, as is reported on Monday, the 4th of October. So you can see at the moment, since the start of the pandemic, there have been 15,394 cases of COVID in RBKC and 23,754 cases in Westminster. In July, we saw the cases increase in the younger age groups, and since then our cases have remained above 100,000, above 100 per 100,000. In the week ending September 29th, RBKC's case rate was 206 per 100,000, and Westminster's case rate was 151 per 100,000 against a London average of 207 per 100,000. Over the past week, we've seen on average 46 cases per day in RBKC and about 53 cases per day in Westminster City Council. In relation to the deaths data, which is also on this slide, since the start of the pandemic, there have sadly been 276 deaths in RBKC with COVID on the death certificate. And approximately, or actually 226 of those deaths were within 28 days of a positive test. In Westminster City Council, we've had 409 residents who've died with COVID on the death cert, and 327 of those were within 28 days of a positive test. So if you move us over onto the next slide, Yasmin, this is just giving you the wider London context. You can see Kensington and Chelsea there, and you can also see Westminster next to Kensington and Chelsea. RBKC has the 17th highest rate in London, and Westminster has got the 3rd lowest case rate in London. The highest case rates at this point in time are south of the river. You can see Kingston there with 327 cases per 100,000. And the final slide is just keeping our attention on the 60 plus case rates across London, because this, of course, is our most vulnerable group. Case rates in the 60 plus are low compared to the other age groups, but we do pay careful attention to these. In RBKC, you can see that our case rate is 106.2 per 100,000, which equates to 36 cases, and in Westminster the case rate is 63.4 per 100,000, which is equating to 29 cases. Thank you very much. Happy to take any questions.
There we go. Do we have any questions at all for Anna? No, I suppose everybody's very familiar with these slides, Anna, so thank you for your update, and let's hope the downtrend continues into winter. Thank you. Good. Okay. On to item 6, which is the Staying Well This Winter plan. We've got Joe Nguyen, for Central London Borough Director of North West London, and Simon Hope, the West London Borough Director for North West London, to present a paper.
Yep. Thanks, everyone. Sorry, I just got this cough, so if I'm coughing, it's just I'm trying to get through this. This agenda item is an interesting one, because I think this is very much a work in progress, and very much us coming in here, coming to the Health and Wellbeing Board to really get input and really get feedback on sort of the direction of travel. So first and foremost, thank you for that. As you know, the winter, it presents numerous challenges for us, for the health and care system, but also not only our residents only, but also our frontline services and frontline staff as well. So this is very much about us trying to look at winter from a more of a community-led and more of a public health approach as well, and how we join up what we call our health and care system together as well. So if you just can go to the next slide, if that's right, Yasmin. So how we wanted to start this is that, we generally go through the winter planning process for the NHS, but we thought we start with our residents, and there's been a lot of community insights work. We had 20 sort of what we call our super residents, who are representatives of different residents in different wards, who we were just testing to see why they were using sort of more of the urgent treatment centres and more of the A&E. It was very interesting for us to kind of understand this, because I think there's a lot of different, I suppose, hypotheses of where it is, but I thought 4 of these examples were really helpful. So I think the understanding of community pharmacies and how much pharmacies can help with sort of the common ills and colds, which rather than going to the GP, and then also just really diving into sort of different sort of just community groups as well, and sort of different cultural sort of ideas and around how we access sort of remedies and how we deal with sort of the common colds and flus as in the second one. And as you can see, newcomers to the country, we've been, we're going to have an update on the Afghan evacuees. So it's just very much, providing that extra support for different groups who have just sort of moved into the borough, indeed our country as well. So, and then also the other aspects around just COVID and just, the loss of family members and the loss of sort of, the loss of somebody who can help us as well. So these are very initial findings, but I think it's something for us to really keep in mind around how much we need to work with our communities and also develop our communities to support some of the sort of, I think, winter issues that are coming up. If you can go to the next slide, Yasmin. So what's emerging for us is really three key pillars. The first one is the community-led one, which I've talked a lot about around the insights as well. And what we're trying to do is work through what is really some of the really priority messages that we're trying to get across. So, the immunity booster campaign, which is around us getting the third vaccine, and indeed we still need to look at the first and second dose vaccines as well. A lot of the public health work that we're trying to do around keeping well, keeping safe, and keeping warm as well. And some of the other sort of messages that we're trying to get across around sort of mental health as well, our talking therapies services, where we have a lot of capacity that could help people with some of their emotional well-being needs as well, and some of the issues around anxiety and just coping as well, and other digital sort of forums that we've made available. So these are some of the areas that we're trying to explore around the community. We're doing a lot of work with our community organizations at the moment, probably more that we need to do. And it's been great because I think we've now been getting a lot more proposals in terms of things that we can work with community to support this this area. The second pillar of this is around system resilience, which is more of a traditional, I would say, winter planning. And it's looking at sort of our same day sort of offer at Soho and St. Charles Hub across both boroughs, really looking about how we can increase that help to prevent people to go into mental health crisis. Looking at MDT working, how can we work better together, for people with long-term conditions, but people with more complex needs as well. And really just working with the local authority and our NHS partners and our other providers around how do we simplify discharge. And I'm sure, James, you can come in more about this sort of step down as well. And then the last part is really focusing on the higher intensity population, people who are presenting more to GPs as well. Is there any additional support, in any support that we can be providing around some of the psychosocial side of things as well? The last one that we're looking at is around the health and care workforce. And I think, I can't speak enough for, on behalf of my frontline colleagues around the last 18 months of COVID as well. So we know this is an area that we absolutely need to focus on to make sure that we are ready for the winter, if you will, as we're going into it. The local jobs for local people, there's already great work that the local authority colleagues are already doing with our local residents around, helping coach people through in terms of and creating those opportunities for local residents to either get NHS or social care sort of jobs as well. So that's the work that we're doing, looking at secondment opportunities, looking at really the recruitment process and how we can actually, make it easier for people to apply and support people through that, and the training. And then looking at as well, just some really good practice around emotional and well-being support that each of our partners are doing, and sharing that across, including coaching, other mental health and mental well-being support, and others as well. And I'll just stop there. It's just really the flavor of where we're going, and a lot of work that we're doing across our partners, the community, in terms of getting this sort of like in place, if you will.
Thank you, Joe. That's really interesting. We had some hands go up. I'll go to Tanya, whose hand went up first.
Good morning. Thank you. I'm from Kensington. I'm a local resident, but also with Health Watch. And thank you very much for this report. The first thing that you highlight is the emerging theme of excess UTC and A&E utilization. What we found in Health Watch is that actually residents in our boroughs who are not fluent in English find having just a triage by a phone appointment extremely difficult, because it's very difficult to explain particular pain, or say trying to raise a shoulder or an arm where the doctor cannot see the visual clues. What is the plan to actually increase face-to-face appointments rather than, unfortunately, encouraging many patients to actually go to UTC and A&E to address their initial concerns? Thank you.
Yeah, thank you for that. If that's okay, we've got Mona and Andrew on the call as well. I don't know, Mona or Andrew, if you want to come in from a clinical perspective as our GP leads for both boroughs.
Well, as it was a Kensington inquiry, I'm Andrew Steeden. I'm the clinical borough lead for West London, and what we are seeing is increasing numbers of face-to-face appointments going forward. So we're hopeful that we will be returning slowly to the kind of levels of face-to-face that we had before, if not completely returning to that pattern going forward, as we offer the opportunity to have different types of consultations in primary care going forward. I think clinically, if anyone is in a position where when they're on the telephone they can't be completely assured about the health of the patient or that they've got a complete story, then I think we're encouraging primary care to see them face to face. Your point around whether the people are then making a choice to go to urgent care centres or A&E ahead of instead of doing the telephone call, then I think we'll have to continue to come up with ways that we can facilitate them coming into primary care rather than going to urgent care centres. But at the moment, telephone triage is what we're using to keep staff and patients safe while we're still coping with the COVID virus.
Thank you very much. I appreciate the concern about the staff, but really this is for those in our communities, Kensington and Westminster, who are actually not particularly comfortable with a lot of English. And again, they may be fluent, but they cannot find, they don't want to take 2 days off from work, quite frankly, because this does have an economic impact. They have to wait for the phone appointment. Then the phone appointment is incomplete or inconclusive. They may have to have then a follow-up appointment where the doctor might legitimately say, come to the practice. And they then have to take a second day off of work. This is for our community members who are not necessarily able to work from home. They're working in Tesco's, they're working in the pharmacies, they're working in the community as bus drivers. So the more that can be done to accelerate the reestablishment of face-to-face appointments at surgeries or walk-in appointments would really be welcomed. Thank you.
So I mean, yeah, we have to be careful with what language we use. Face-to-face appointments were never stopped. They've certainly been managed during the peaks of the crisis, but they've never been stopped, and they're still available now, and they're increasing in numbers as we move out of the COVID phase. So I think you'll continue to see them increase. We are getting feedback, and I understand Healthwatch is getting this similar feedback too, that there is a sections of the population who actually prefer the telephone consultation / online consultations that primary care is beginning to offer in greater numbers. What primary care is also dealing with at the moment is its capacity to offer this wide range of consultations. So the numbers of contacts that primary care has on the last readings that we had was over 30% higher than what we were doing pre-COVID. So GPs are actually working incredibly hard to offer the wide range of consultations that's available. But I'm sure that all of us are trying to increase the numbers of face-to-face too. But but we're also trying to maintain the range of consultations as well.
Thank you. And we've got. I think we've got to make sure everybody gets a chance to ask a question, I'm afraid. But so I'm going to move on to Councillor Navsika Butler-Thalasis there, please.
Hi, I think Mona was trying to get into the last question, but I'm going to say a couple of things that relate to that. So firstly, the issue with patients that don't speak English is that interpreting services should be used. That's the genuine solution, and that should happen whether it's a telephone appointment or a face-to-face appointment. And the feedback we have is that these services are not used anywhere nearly as often as they should. So there should be an increase in the use of interpreting appointments within interpreters if we're going to use telephone appointments, because people who could perhaps manage face-to-face can't manage on the telephone. And the other point I wanted to bring up is you mentioned the point about patients keeping warm this winter, and obviously that this is an area where collaboration with the local authority is very important, and it'd be good to know what the local authority is doing to ensure that, especially with increasing fuel prices, that we can keep residents warm this winter. Thanks.
Thank you. I don't know who from the local authority would want to take the item for keeping warm this winter. Perhaps that's something we could give you an update on via email, Nasika, if that works for you, if we don't have somebody available here right now. Anna is. Perfect. Thanks,
so I'm happy to pull together a sort of a written update and share that with Councillor. So I'll do that within the next week.
Thank you. That's much appreciated. And Mona, sorry if I got that wrong. If you'd like to go next.
That's all right. That's all right. No, I was just kind of responding to part 2 of the question earlier about face-to-face appointments, because I can represent Westminster. And in terms of facts, I mean, it's a really good question. I know it's been, heavily kind of mentioned in the press as well, but I wanted to reassure, at least for Westminster, our stats clearly show that we're about 70+% of our appointments are face-to-face. And I've just shared all this data in detail with Health Watch as well, and with Olivia Clemmer, and also various other people. So, just to reassure again that we are offering them up, and absolutely Nafsika was good. Just said what I was going to say, that we are using the interpreting services. We're also very well aware that we have got a large BME population, and yes, telephone triage does occur, but we are insisting on everything to go via e-consult. If a patient prefers to be seen to discuss an urgent issue, then urgent appointments, which are face-to-face, are occurring within my Westminster patch. So it was just a reassurance.
Thank you, and good to hear. Kathleen, you are next.
Yeah, thank you. It was also just to reply. So I'm Kathleen Isaac. I work at CLCH and we run the St Charles Walkin Centre. And again, we are absolutely prioritising people on the same day. So recognising the point about, people having work. So our hours are 8 till 6 to try and really make sure people have the opportunity to come in around their working hours, and also linking in with interpreting services as we need to. So just wanted to provide that reassurance for the same day.
Kathleen, just to check, is the walk-in centre still only by booking, or can people actually walk in?
At the moment, it's still by booking, but you can self-refer. So you can go via your GP, via 111, or you can self-refer. So it is open for people to self-refer in, but you can't just walk in. We need to make sure there's a slot to ensure.
Fine. Well, yes, we can contribute to the signage on that one. All righty. Thank you all. I don't know if we have any other questions on that one. It's obviously a very important issue going into the winter. If not, it's the same team again presenting a paper on the ICP.
I can kick this off, but I think the plan here is that James presents the sort of ICP overview. Sorry, there he is. Sorry, James.
Thanks. That's absolutely fine. So I suppose our ICP has probably come quite a long way since we commenced, namely in terms of our ability to deliver against some of the objectives set as an integrated care system, but also in our local objectives. The executive team met with our NHS colleagues to review our progress to date, and I think it was really our first opportunity to describe what we've been able to achieve. We discussed our ability to improve discharge and the impact that that's had in the reducing need for frail people to return back into hospital. We also discussed our plans around supporting public health management and the upcoming plans to increase that at a PCN level. So our 2 collections of practices in both areas, and really working on understanding health inequalities and making change. We also discussed our ability to bring together a more consistent multidisciplinary approach, and that's not just around health, that's around health, social care and the voluntary sector. To that end, I'm really pleased to describe to colleagues that we meet on a Tuesday morning at 8:30. It has all partners present, voluntary sector colleagues, local authority colleagues, health colleagues, really starting to understand the present operating performance of the out of hospital and hospital space on a weekly basis, taking each week one of our key planks of work. Specifically, it could be around children's, which we had this week, and we then start to analyse what we're doing and whether or not it's having impact. It's a really good opportunity for broader colleagues to come together, offer advice, suggestion, and engage in the work. Moving forward, we will be discussing, and we're very pleased that we'll be coming together as a broader system and working with the Health and Wellbeing Board to understand our governance more broadly together, how we describe our work as a system collectively, and just understand what the objectives will look like next year. We recognise that we've got health inequalities across both the city and the Royal Borough, but what we want to be able to do is start to describe what we're going to do about managing that into next financial year. I was going to leave it there and probably just go to questions or anything that Simon or Joe wanted to flag.
Anybody have any comments to make on this one? No. James, perhaps it might, whilst we have a little bit ahead of the agenda, if you could just reiterate exactly what the priorities for the ICP are, so everybody on the call is aware of them.
I was just wondering, we'll send a slide around as well, just so everyone has got that. But in effect, we've got managing, here we go, thank you. Do you want to go to the next slide? Thank you very much. We've got obesity. We've got care homes, discharge and children and young people, and those ones are our local flavour. And then we've got population health management, PCN, so primary care development at place and at ward level, integrated care teams, which is that team that wraps around GPs, our diabetes strategy and our COVID response, which brings into vaccination. My gut feeling, colleagues, is that a number of these will continue into next year. So we're not suddenly going to stop a plan to deliver population health management. It's an absolute plank of reducing inequality. So that, I would imagine, will continue. I would imagine the COVID response will continue. I hope it doesn't continue past next financial year, but, you know, never say never. And then I think we probably need to discuss more broadly as a Health and Wellbeing Board, are some of these objectives, our local objectives, the right objectives moving forward? And I know local authority colleagues are keen for us to consider air quality and the impact that has on our population.
Thank you, James. Yes, absolutely. And I knew I'd seen a slide like this somewhere, so I knew it was coming. Councillor Mitchell.
Thank you, Chair. James, thank you for that. The colleagues are so far been silent coming forward with questions, I think because there is still confusion and lack of clarity on behalf of partners with the development of the ICP and ICS. We don't really know collectively, that is, as a community, we haven't really got to grips with the concept yet. And I know that in the Whitehall phrase, the guidance is awaited about the role of health and wellbeing boards in this new world of ICPs and ICSs. But could you perhaps give some initial thoughts of how the priorities and policies which we discuss at the Health Wellbeing Board will be informing the ICS and ICP priorities in the future?
So I was going to be eloquent. I think it's probably best to say, colleagues, that we are merely a happy band of brothers at the moment, because we don't have any understanding of what that statute would look like. But I suppose I'm going to sort of start with this point that historically, I think our health and wellbeing boards have had individuals coming to health and wellbeing boards presenting on organisational positions. as opposed to where I think our ICP is going to get to, which is the collective group of healthcare voluntary sector organisations delivering against the objectives that we set as a health and wellbeing board. So it becomes the vehicle for delivery, so that we can actually sit in public and be scrutinised around, well, what are we actually doing to improve the health and care of our population? And that's very separate from me as the Chief Operating Officer of CLCH saying, well, what are we doing about setting up walk-in centres? And a really good example of that is when we met to describe, well, you know, reopening up St Charles, how is that going to fit? What are the key issues that we have for access at the moment? What is the sort of offer that we think we should offer to our local residents, rather than I'm just going to turn that on? Moving forward, I think what we will start to see is that with the Health and Wellbeing Board, we will start to form what our local priorities are. We will, as an ICP, inform the ICS of what our local priorities are. And the ICS in and of itself might inform local places what a broader issue might be. For example, one of those would be diabetes management. So I don't think it would be inconsistent of any of us to suggest that we could do better in managing diabetes in our place. We recognise, though, that in the Royal Borough and the City of Westminster, we are ahead of some other local areas, and therefore I think there's a responsibility of us as clinicians in particular and leaders to support other boroughs to understand the way better care would be provided. Another example of that would be homelessness. So as we discussed before, we may take a decision that we have a local priority to improve the way we support people who find themselves homeless. We may take that as an ICP decision, but more broadly in conversations with the ICS, we might have the conversation that says, well, actually, we think this is a real priority. And I'm starting to see some of that occurring. So the work that Joe described before around homelessness, in my conversation with the discharge teams, we were describing, well, I understand how that's going to work in the Royal Borough and the City of Westminster, because we've got a pedigree of much more integrated homeless services. Although I'm looking at Anna on the screen, and I'm entirely sure that she doesn't sometimes feel that from an Imperial point of view. But if I was to look to our broader issues that we might have for discharge for Brent and Ealing through Imperial for people who find themselves homeless, we don't have that same relationship. So for me, it's about shaping what we think what we need to do in our ICP, and supporting the broader ICS to understand how we would improve health and care moving forward. That doesn't say, though, that, and I think we'd all be very naive, a number of us have worked in systems for a very long time, and we may get central requirement from central government to deliver against a key national objective, and we have to accept that. And that will be a bit of a reality, and that might have a bigger impact for NHS providers necessarily than local authority, because I think we all recognise the different statutory requirements that we would have.
Thank you, James. I see Olivia has her hand up as well.
Thank you, Chair, and thank you to James. I know that in our boroughs, we're taking a very pragmatic and sensible approach upon drawing from existing consultation material. I think that I've shared the borough plan engagement we did in 2020 with Joe and colleagues. And I'm sure we're building on the consultation experience from the long-term plan work that was done just 2 years ago now. So I think it's been very sensible to draw upon that evidence and work and investment, so that people don't feel they're trying to contribute and tell the same story again. I would just like to flag the unexciting issues that we also hear about, and that's patient transport. We had our local committee meeting last night, and the issues around patient transport are there. So whilst I welcome the clarity that James has given and a very practical and sensible way forward, it's just to flag some of those other other elements that affect patients every day. So we're hearing that patients with large wheelchairs are struggling, or London Ambulance Service are not willing to take them. So there's nuance as always in this, but thank you, James, for that solid outline of priorities coming. Thank you.
James, your hand's gone back up again.
Could I respond? I think one of the challenges I think we're going to have is how do you meet strategic objectives? So we're setting these things out as strategic goals versus dealing with the present needs or issues that our residents are facing. And I think we're going to need to be able to do that. I worry sometimes we often forget that we have to deliver the day jobs and also deliver against strategy, and we try and lump too much into delivering strategy and forget that at the end of the day something's going to happen that we're going to need to sort. So it's how we balance that. This doesn't though say that we wouldn't do other things, and a really good example of that is that in our ICP and with our local authority colleagues in particular, Janet and Graham Call from CNWL with colleagues have recognised that we need to extend our offer for individuals who are neurodiverse across the child and adult continuum. So we have agreed to actually extend the scope of that work, and I think it's really important that we do that and just not keep it in a children's offer. I'd probably just finish though, and some colleagues have heard me say this before. I recognise the statutory challenges that local authorities might have in relationship to an ICS and the fact that we don't have an outcome yet from Whitehall. But at the end of the day, we are both, some of us are providers, some of us are residents, and you can be an organisation in place at the same time. And I suppose I'm in the space at the moment which says, yes, I'm the COO of the trust. I'm also the ICP director, but I'm also part of the integrated care system. So we can actually be all three things because our residents do move. They aren't, as the councillors have said, they aren't necessarily always tied to the borders of the things that we put around them.
Thank you, James. I suppose just one sort of question from me is I'm always very sceptical of systems without being able to prove their effectiveness. So I suppose my query is really, how are we going to make sure that the work the ICP does is evident and sort of tracked to the point where actually we can evidence that had it not existed in the first place, anything would have been different. So
yeah, so interesting you say that. We met today as a senior leadership team and I asked the very specific point, where are the key performance metrics against these things that describe success, that describe the amount of work that we've done and whether or not it has had any value in particular. Now, they may be process metrics, they may be outcome metrics, they may be experience metrics. And we've got some of those built in, and what I would imagine moving forward, and I think we might discuss this as a health and wellbeing board more broadly, is what does assurance look like in a new world as we're working together?
Thank you. I don't see any other hands up. So that takes us on to item 8, which is Grant Akin, the Borough Head of Health Partnerships, providing an update on the KNC investments to Better Care Fund. So over to you, Grant.
Yeah, thank you very much. Thank you very much, Chair and members. This paper is really just for noting. It's to provide you with an update on the Better Care Fund across Kensington and also Westminster. The main one, just to note, at the time of drafting this report and publishing it, we hadn't had the national guidance. That's now been received. And on section 3, where we just talk about the assurance process, the only change is that slipped by 1 week. It's now the 16th of November when we need to submit it back to NHS London. So really the only other update also is that we will need to make that submission offline. So once we have worked with health partners on that, realigned any parts of the BCF to respond to those local priorities, then we'll be circulating it offline to the Health and Wellbeing Board chairs, if that's possible. But I'm welcome to take any questions on the report.
So I'm looking for some hands. Anybody got any points they want to raise to Grant? Bit of lose it or lose it. Grant, I suppose you've answered everybody's questions.
It's good to hear.
Well, I'm sorry you prepared for a grilling and didn't get it. So anyway, maybe next time.
Next time. Thank you very much, Chair. I'll welcome it.
Thank you, Grant. Well, given that was much shorter than expected, we find ourselves on AOB now already, and I know we already have two items there. The first one being Afghan resettlement, and I'm looking to the group to who will be speaking on this one. It's not noted for me, I'm afraid. Janet.
I can certainly give an update from a health perspective if you want me to kick off. Obviously, there has been an awful lot of work ongoing within the team. So basically, I wanted to start off by emphasising what a fabulous sort of joint partnership working the response has required and has delivered. I think it will be a real benefit for our relationships going forward. It really does feel like this is the ICP in action. This is what the Integrated Care Partnership is all about, all partners pulling together and working in a responsive way. So we have put a response in place from a health perspective. It is continuing to evolve. I think it's no mean feat to say it's been a little bit chaotic in terms of starting it because of the way that the residents arrived and the multiple agencies, etc., that have been involved. So we have been working through that. And again, that's why the partnership working has been really helpful. So we are delivering and plan to deliver the health response in line with the requirements set out by NHSC and the other departments. The initial focus has been supporting the triage to assess immediate health needs and assess sort of the existing health requirements, registering residents with local practices and ensuring residents are supported to navigate the NHS systems, and also ensure that the mental health and wellbeing needs are assessed and met, and recognising that this will all change over time as well. So the immediate needs may well evolve and change from a health perspective as time evolves. There's a lot of work that has been done and a lot of work to do to mobilise in a short period of time. And health partners in community, acute and mental health trusts have all worked together to mobilise that. So we're covering our mental health, maternity, community services for children, etc. We have regular meetings to coordinate the information and response and share learning and experience, because we are finding different hotels, different issues, and we by sharing that we can work together. So what have we done already? We've got the West London GP Federation coordinating and providing the immediate response and facilitating registration. They are working closely with the surrounding practices on that registration process. We have not yet completed all the triaging for all of our residents, but that is progressing, and there is a time frame for that to be delivered over the next week. And I'm just trying to get by the 22nd, all of the triaging will have been done, and we are talking around about 1,300 people across the 4 sites in the Borough area. The registration process has also commenced. Lower numbers have been registered than triaged, and registration priority has been based on clinical prioritisation. So anything that's been identified for a pregnancy, or a 2-week wait for a suspected cancer. And we also know that some patients have also registered with practices in the initial few weeks. So we're capturing that information as part of the triaging as well. Any red flag patients, so patients that we identify as being needing to be required, sort of prioritised registration, should be registered by tomorrow. So that's really positive. The Federation is kind of looking at the moment to sort of the scope to speed up all of those processes to try and bring forward the target of the 22nd for the completion of the assessments. And it's fair to say that the availability of GPs is one of the rate limiters. There's an awful lot of work going on in our practices as core business already. So getting GPs that are then available to support this additional work is an ongoing part of that process. But we know that our practices are continuing with our vaccination booster campaign and flu-IMS, for example. We are also, as the triaging completes and the first 2 hotels that will be completed, which are The ones with slightly lower numbers are Olympia and the Copthorne. Again, that resource will then be moved to the Radisson Blu, which has got higher numbers, and the Metropole in Westminster, which has got the largest number of residents. Some of the other issues that we have been dealing with are things like prescription charges, and arrangements are in place with local pharmacies for dealing with prescription charges until residents have got recourse to funds or eligibility for exemption from prescription charges. We've had to do some workarounds, ensuring that there isn't any disruption to the supply of prescription medicines. But we do have still some issues that we are continuing to work through around medicines. For example, the sort of safe and legal access to over-the-counter medicines. It's been a little bit of a mix and match in terms of the arrangements, and we just need to firm that up and make sure we've got some consistency that is safe and effective. We've got cover as anybody would have who's registered with a GP from 111, and the access to urgent treatment centres, etc., out of hours. And the main aim would be for us, as we transition to registration, for the core delivery of health services to be done via the practice. So again, as we transition into that, there will need to be a bit of additional work done. And for example, we are working through information leaflets that give details of local contacts to give to residents, and also a detailed pathway document that's being developed that can be shared with partners, so everybody has got the correct information, that if anybody's dealing with any of the residents, we've got the consistency in information. The other specific areas of work are maternity and in-reach services for our maternity patients that are resident in the hotels. We've had several births since the evacuees have arrived, and working closely with both the acute maternity units close by, so Chelsea and Westminster and St Mary's. And CNWL are providing the mental health and wellbeing assessment and support, and moving into a position where we're working through how the trauma assessment can be done most effectively, again helping support emerging needs and trying to reduce the impact of some of the experiences and trauma that the individuals have already experienced. Alongside that, the community services for children are particularly involved with the children's centres, the health visitors, and community services supporting the immediate needs for our children and young people. And going forward, that will include things like the childhood and now the childhood immunisations that will also need to be done. Sorry, that was a quick rattle through, but I think I've covered most of the things. I'm very happy to take any queries or questions.
That was great, Janet. Yes, you covered a lot of ground there. Does anybody have any questions at all?
I can provide an update from a children's services perspective, if that's helpful. It's Etienne speaking.
Thanks, Etienne. Well, why not? Yes, let's hear everything, and then we can take questions at the end.
Okay, great. So just in terms of numbers, the total evacuees in Kensington are just over 750, and in Westminster just over 800. Of those primary age children, there are 153 in Kensington and 164 in Westminster. And it's worth pointing out that sort of over the last few weeks that the focus has really been on getting the primary age children enrolled and learning to speak English, so accessing ESOL courses. The current focus is very much on getting the 123 secondary age pupils in Kensington and the 90 secondary age pupils in Westminster enrolled into schools as well. It's worth mentioning again that in Westminster, 20 of the 90 have been enrolled in a Hammersmith school, and we also have an additional 25 college-age students. The other cohort worth pointing out is 2 to 4-year-olds. So in Kensington we have 75 and in Westminster 74. So we know that well over 85% of the evacuees speak little to no English, and the sort of breakdown of language is just over 58% speak Pashto and 42% speak Dari. So Pashto seems to be the more popular language. Staff have been really working with partners to focus on needs assessment and those triaging services, but broadly working with partners and assessing needs and sort of identifying trauma and providing services accordingly. The focus has been on enrolment, and while children, young people and families are waiting for those enrolments, council staff have also developed a program of activities to keep young people and families occupied during the day. Thank you.
Excellent. Thank you, Etienne. Does anyone have any questions for either of those? Lena, thank you. Go ahead, Lena.
Hi, thank you, Chair. Just unmuted. Yes, the Mosaic Community Trust, which is a community-based organization operating in Church Street area, close to London Metropole, is working very closely with the refugees from Afghan who have just. And I mean, can we not please use the word evacuees? Sounds so unacceptable, because we've been talking to the Afghan refugees. They don't even like to be called refugees, and I don't know what they would say if they heard that we are calling them as evacuees. And they're also not at all very happy being isolated as refugee communities in these hotels. Like, for example, in the London Metropole, there are over 500 families staying there, and they're all, isolated, and they're not having appropriate arrangements or facilities to come out and have interaction with local communities. And fortunately, Mosaic, which is a very small community-led, community-based organization, is able to offer them such facilities. They come and interact with local communities. That is making a huge difference to their mental health and well-being. And it's not always about giving them, mental health interventions in the institutions, but also in the community. That kind of social interaction is making a huge difference. And I'm just wondering if the providers, health providers, could partner with community-based organizations at the local level and enable them to have this kind of social interaction within the community. And the local communities are so forthcoming and embracing these refugee families and offering them a lot of friendship and help in the community. So I just want us to consider other ways of supporting the health and well-being of the Afghan families who have newly arrived from Afghanistan.
Thank you. And just to sort of respond to that in some way, I'm sorry, evacuees, you're absolutely right. It's not a good term, and I think it does come down to Home Office terminology, and I think I'll just call them hotel residents for the moment, perhaps. But
Thank you very much. Yeah.
Sure, but in terms of the activities, I think it's worth mentioning that a programme of activities has been put together both in Kensington and Westminster, and the offer ranges from, so in Kensington, we're arranging for creche facilities from a library that's very close to the hotel, as an example, and we're also organising childcare for under fives as another example. Last weekend, I know cricket is very popular, so we've been organising in Westminster trips to the Oval cricket grounds for groups of. Oh, sorry, I'm seeing a shake of the head. So, but various sports have been arranged and are taking place. So, you know, for young people especially, the sports offer is quite robust. So, completely take your point. It shouldn't just be about services, but also about activities, and we are coordinating that across both boroughs.
Thanks. And Councillor Mitchell makes a very good point about mentioning locations of hotels. Okay, if we don't have any other comments, will be the next item to talk about is. Oh, who's
Jem,
that?
I will. Sorry, it's Anna. I'll just step in with the public health update in terms of support. So Janet has touched on some of these items. So our environmental health officers have completed risk assessments with all of the hotels and are working to support them to undertake the key issues and actions identified there. We're working very closely to reduce risks of COVID-19 and other infectious diseases, including testing approaches across the hotel, and there's good access to regular testing in all the hotels for all our residents at the moment, including information in leaflets with regarding this. As Janet's mentioned, we have a focus on safe baby feeding, and we've been translating information and distributing that, and infant formula, liquid infant formula is being supplied because of the softened water in the hotels being unsuitable. Key health risks for COVID include those wider infectious disease issues. So as Janet's mentioned, we're working very closely around awareness around TB and measles, and the rapid immunisation and screening is really critical with regard to TB, measles and wider infectious disease. We supported the organisation of the COVID vaccination clinics, some of which have been delivered on site and through the use of the vaccine bus, but we've also supported by transporting guests to our community vaccination sites as well. There's considerable work going on supporting NHS colleagues with the development and translation of leaflets to help guests understand access and sources of health support which are available to them. And we're continuing to work with all the partners to improve their health and wellbeing.
Thank you, Anna. That's very helpful. Good. Okay, so we're on to just mentioning the away day that we've got organised. This is on the 19th of November at Westminster City Hall between 10 and 2, and anyone who has not yet registered can still do so. So I look forward to seeing many of you there. And if there's nothing else, we move to item 12, which is the end of the meeting. And all I have left to say is that the next meeting will take place between 4 and 6 p.m. on the 25th of November. And I'll submit my apologies now because I'll be on a much delayed honeymoon for that one. So Tim, I'm afraid it's over to you for that. And thank you all for coming this evening. Thank you.
Thank you. Bye.